So I chose a case that we had a month ago in our department. This is a young man who was admitted in July for a first episode of acute pancreatitis, a mild episode of acute pancreatitis. He has no previous medical history, and he drinks about 4 or 5 units of alcohol, but not like 4 or 5 days per week. He does not smoke. He says that he lost some weight, but because he does sports, and he has definitely increase in lipase that confirms the diagnosis of acute pancreatitis, and also some liver function tests that are also abnormal. But he's rapidly gets better, outcome is good, so he leaves the hospital. He has undergone US that shows no biliary stones, no sludge, but an MRI shows that there is a double dilation, common bile duct and pancreatic duct. No obstacle, but we think at this point that there might be an ampullary lesion. So he undergoes US, where we confirm this double dilation, and we also see that he has submucosal ampullary lesion of 25 millimeters that seems to be restricted with no muscular invasion, and he is scheduled for endoscopic ampulectomy. So he has endoscopic resection of this lesion with a snare. There's no submucosal injection of saline or adrenaline saline, and he has a prophylactic stent insertion. As we see here, everything goes well. After the resection, there is no bleeding during the procedure. We cannulate the parenchymatic orifice, and we put a prophylactic stent. So things up to now go well. But this is the lesion. But what could go wrong during this procedure? And I turn to my moderators. What could go wrong during this procedure?
So these guys don't look very happy.
No.
They might think about perforation.
Wrong. Everything goes wrong.
They might think about bleeding or perforation.
Bleeding, perforation, yeah. What can happen?
Wrong histology.
Also,
normal papilla.
Yes. So acute pancreatitis is also one of the favorites. That's up to 15%. Perforation, as Jorgen said, up to 4%, and bleeding, which is the most the usual suspects, let's say, during these kinds of procedures. So, what do we do during the procedure to avoid some of these things? So we put a stent. Is this a good idea, a bad idea? So there have been 2 randomized trials and many retrospective cohort studies, and this is a meta-analysis that put everything together. And you can see here that it's effective to put in a stent regarding the incidence of acute pancreatitis post-ampulectomy. So yes, this is a good idea to put a stent to prevent acute pancreatitis. What about submucosal epinephrine solution? So this usually before this trial we used to inject before ampulectomy, but you didn't really have a good lifting on the ampulla because it remains at, with the muscle layer and everything. So this study showed that for isolated papillary lesions, there was no real interest to inject submucosal solution with adrenaline to decrease adverse effects, including bleeding. So no submucosal injection. We didn't do it, but doesn't seem to have a special interest. So if we take one of the large multi-center studies, the prospective studies, this was a French study, 120 procedures, 93 patients. We see that the major complications are acute pancreatitis, bleeding, perforation. Also, we have biliary infectious complication if there is invasion of the biliary tract, and you can see also there was 1 case of mortality. So it's not something to be taken lightly. So let's go back to our patient. So everything went well. He was in the ward. I went to see him with my colleague, and he was feeling kind of queasy, really unwell, not really pain, but it's kind of gray. So he said, I have to go to the toilets, and we helped him to get up, and at that point he just leans down, and he's out. He made a vasovagal reflex, and he lost consciousness. He had a slow heart rate, and he quickly came back as soon as we lift his feet up. He had no melena or anything, but we had to start give them IV fluids, and we did lab tests. And at lab test, we saw that his lipase were normal, and hemoglobin was 11, which is not abnormal, let's say, but pre-procedure, 2 weeks before, he had 15 and a half. So there is something going on here. So one of our suspicions that he was bleeding, even if there's no exteriorization, no melena. So we took him to the endoscopy unit early the next day, and this is what we see. So there is blood, as you see. So one of the important things here is to try to define the origin of the bleeding, to be able to give a local targeted therapy. So this is what we're going to do with an ERCP catheter. We're going to put some water to try to determine exactly the point of the bleeding. And as you see, the stent is still there, which is important, because the second point that is important when you're going to take care of this issue is that you have to identify the pancreatic duct to avoid either using coagulation or putting a clip there. So if the stent is not there anymore, you have to try to find the pancreatic duct and put a stent again. So here we're using a coag grasper. We found the point of the bleeding, and we're going to coagulate very selectively this point. This device is interesting because it's not coaptive. You don't have to put pressure in an area where it's just been a resection. You want to avoid perforation. So this is a good device to treat bleeding after apulectomy, and people that do ESDs know this device very well, of course, and it was useful in this case. As you see, the pancreatic orifice is identified nicely on the right here, and there's no more bleeding. So that finished well at this point. So the devices that might help you in this case, as we use here, this coagulation forceps with, we use soft coag, effect 4 and 50 watts, but you can go up to 80 watts maximum. There's less risk of perforation, the other coagulation device in this setting. Another thing that could be useful is to inject with a needle, and you have the stainless steel Teflon coated needle that can go easily through the duodenoscope, because of course you will use a duodenoscope here to have a very nice lateral image, and this can pass easily through the channel and the elevator. And also clips that were rotatable, and clips with open close possibilities also will be a good potentially used device to clip if you have a visible vessel or something. So this is from the Sydney group. They grouped their conventional papillary adenomas and the large spreading lesions around the ampulomas. They had 125 patients with 28% of intraprocedural bleeding. And this is the different treatments that were applied. You see the through the scope clips and coagulation forceps are the top two. And regarding the predictive factors, lesion size and procedure time seem to be a predictive factor for intraprocedural bleeding, as well as piecemeal resection and the larger lesions. And the delayed bleeding, this was almost 17%. Lesion size seemed to be the major predictive factor for delayed bleeding, but interesting, not intraprocedural bleeding. So any other solutions? Hemospray, hemostatic powder can be a solution if the local endoscopic treatment fails. In this large nationwide study, there was 261 patients. There were some cases of post-ampulectomy bleeding, and they saw that the predictors of failure was 25% had failure within the first 3 days, was spurting bleeding, so really the arterial bleeding and hemodynamic instability. and there was only one mild and two severe adverse effects. So this could be also a potential solution. There have been some studies with the matrix-forming gel, the Puristat, also that is being used after ESD. And in this French study, there were 3 ampullary tumor resections. And finally, this Italian study, they used fibrin glue. So what happened to our patient? He went well after the treatment. He did require 2 units of blood and iron, and this is the outcome of his hemoglobin levels, which went up. The results of his resection was a neuroendocrine tumor grade 1. Lateral margins were negative, but deep margins were positive. So this was not completely curative, unfortunately, and so he might require surgery. So to wrap up, post-papillectomy complications include acute pancreatitis, bleeding, early and delayed, and perforation. You have to keep a high suspicion even if there's no per-procedural bleeding, like in this patient, and there's no overt bleeding, like when he did this big vasovagal reflex, there was no melena at all. He never had overt bleeding, but it was the problem here. During the treatment, identify the pancreatic orifice. The prophylactic stent could be also something that will help you if there is bleeding, and local control after identifying the bleeding site with injection, coag forceps, or clips. And MR-spray could be a solution in case of failure. So please come to Dublin and to Brussels. So that's your agenda, your Congress agenda for the year. Thank you.
So thank you very much, Mariana, for the great talk and clear messages. The case is open for discussion. Any comments? Please.
It was a lovely case. So I was called one night, I was on call this week to about a post-ERCP bleed. I don't do ERCP, but I'm the endoscopist on call. Now, luckily, they didn't need scoping. They were stable overnight. But what would you advise non-side viewing, non-ERCPists who are on call in that situation? Do you put a forward viewer down and do what you can do, or does it have to be somebody?
Well, you can if
wield a side viewing scope.
If you can put a forward scope down, but it's very difficult to do any therapeutic control here with a forward viewing scope in this situation. So you have to have a backup.
Well, if you do so, a cap might help.
Yeah, maybe a cap. Yeah, better a cap than not a cap.
So if you have a large resection, and would you think about rescheduling a next gastroscopy just for control at the same day? Does that make sense, or do you wait for clinical symptoms?
Usually we wait for clinical symptoms. But if there is intraprocedural bleeding, even if it doesn't seem to be a predictive factor, we would like to check the next day, maybe just to be sure. If you have bleeding, you control the bleeding during the index procedure. I would like to control the next day, even if there. But in this case, everything went well, so we wouldn't have done it.
Although this, Jürgen, so at least if you look at the peptic ulcer bleed literature, so there's no data to show that a predefined follow-up endoscopy the next day actually does anything, and it's not recommended, but it's a different patient population. Is that different than this if you're having intraprocedural bleeding? I don't know.
I have to admit I'm fond of a scheduled procedure the same day because you have a more controlled environment than having somebody coming in the night. Because you know the lesion, whatever, you know the resection site, so I have the same operator doing the procedure later during the day, 2, 3, 4 hours later. For larger lesions, especially at the papilla, I like that idea.
So, well, and in this situation, there's another advantage, which Shuan just pointed out. The person who may be on call that night may not know how to drop a side viewing scope to take a look at that site. So that may be another advantage for somebody doing it.
That person wouldn't be on call in our hospital, but
but I don't think that's the norm around the world, to be very honest with you. Although personally, I have to say that I think it's important that gastroenterologists, even if you don't do ERCP, if I can drop a duodenoscope, I don't do ERCP, I think anybody can drop a duodenoscope. It's not that difficult to do.
Yeah.
Well, finally, maybe we ask a question to the surgeons. Should submucosal tumors be done endoscopically? I mean, there's a substantial risk of deep margins not being free.
Well, thank you for the question, but this depends very individually on the case. I mean, this is very difficult to decide in total. There are some limits, of course, and especially if there is suspicion of malignancy and aggressive tumor, then surgery would be, of course, more appropriate. But what I wanted to ask to you, how many transfusions did the patient
Yeah,
get?
2 units.
2 units.
Yeah.
That's too much.
Yeah.